This video talks about pulmonary hypertension. If you want to follow along with me, you can feel free to do so by going to page 564 on pulmonary hypertension, first day 2012. Okay, so when do we call it a pulmonary hypertension? What's the pressure in the pulmonary artery when it's normal? The normal pressure is 10 to 14 millimeter mercury. For pulmonary hypertension, it has to be greater than or equal to 25 millimeter mercury. And someone with pulmonary hypertension, and when they're exercising, they are going to have about 35, greater than or equal to 35 millimeter mercury. Okay. Now, how do we treat? Okay, before we go on to treatment, let's talk about primary pulmonary hypertension. Okay. Well, primary pulmonary hypertension happens due to a particular gene called BMPR2 gene. This BMPR2, what it does is it inactivates the vascular smooth muscle proliferation. Okay, it inactivates vascular smooth muscle proliferation. So BMPR2 gene usually does that. But in the absence of BMPR2, there is vascular smooth muscle proliferation, unnecessary vascular smooth muscle proliferation, and we end up having abnormally thick pulmonary artery causing pulmonary hypertension. Now, how do we really treat pulmonary hypertension? We use the drug bosentan. Bosentan, what it does is it inhibits endothelin receptors. Okay, it inhibits endothelin receptors, so it will inhibit vascular smooth muscle proliferation. Vascular smooth muscle proliferation. Now, this endothelin can be given in primary and secondary, but you can see that how exactly it's going to inhibit the proliferation. The job that was to be done by BMPR2 gene, now bosentan is going to do that job. Anyway, so that is pulmonary hypertension. Now let's move on to secondary hypertension. Now, what are some of the causes of secondary hypertension? Number one would be COPD. What COPD does, it destroys the lung parenchyma. As a result, if the lung parenchyma is damaged, so imagine this is the lungs, then there will be pooling of blood in the pulmonary artery, causing pulmonary hypertension. Okay. What about mitral stenosis? Mitral stenosis is going to cause backflow, which is going to backflow onto the pulmonary artery. Recurrent thromboemboli. Recurrent thromboemboli, what it's going to do is going to come and sit on the pulmonary vessel, making it a little bit thicker, causing hypertension. Autoimmune disease. Now, autoimmune disease can cause pulmonary hypertension two ways. One is sclerosis, and that kind of makes sense. There is sclerosis of the vessels. That's one way. The other way is intimal fibrosis. Now, when intima becomes fibrosed, what happens is the media hypertrophy. So there is medial hypertrophy. When there is intima fibrosis, there is medial hypertrophy. So that's another way autoimmune disease can cause pulmonary hypertension. Left to right shunt. Increase of stress, increase in pressure causes also endothelial injury, which endothelial injury is eventually going to cause pulmonary hypertension. Last of all, we have sleep apnea or living at high altitude. So this is the thing. I mean, you might think that living at high altitude is a good thing. Yes, it can be a good thing, but it can also be a bad thing because it can cause hypoxic vasoconstriction. Now, yes, this is not pathologic. I mean, as soon as you're off the high altitude, you're not going to have hypoxic vasoconstriction anymore, but during that time, you're going to have hypoxic vasoconstriction. Now, how do people really die due to pulmonary hypertension? It first starts off with severe respiratory distress, leads to cyanosis and right ventricular hypertrophy. Then, eventually, they're going to have cor pulmonale, and a decompensated copramine. Okay, copramine will not be able to be decompensated, leading to death. So that is all about pulmonary hypertension. Now let's do a question really quickly to kind of seal the deal. Now let's say a 54-year-old man comes to the physician with his wife. His wife says that his husband is always complaining of a daytime sleepiness. He is always tired, and when he's sleeping he always snores, and at times he even stops breathing. Now the question is, this patient is at increased risk of developing which of the following? Okay, so you'd have to pick pulmonary hypertension from that. It's because during sleep apnea, so obviously this patient was suffering from sleep apnea, there is going to be hypoxic vasoconstriction, which can eventually lead to pulmonary hypertension. Now let's move down to pulmonary vascular resistance. That is also page 564, just after pulmonary hypertension. Now pulmonary vascular resistance can be calculated by using this equation. P pulmonary artery, so pressure in the pulmonary artery minus pressure in the left atrium. So the difference between wedge pressure, left atrial wedge pressure, and the pulmonary artery divided by cardiac output is going to be our pulmonary vascular resistance, the resistance provided only by the pulmonary vessels, minus the resistance of the wedge pressure, right? We just want to find, that's why we're subtracting that from the pulmonary artery pressure. So that's one way of finding out PVR. The second way is using this universal equation, which is also used in physics. Delta P is Q times R, where P is pressure, Q is flow, and R is resistance. In this case, R can be R can be broken down into other factors when we're talking about this vessel. 8 times viscosity sine. I don't know what it's called, so if anyone knows what it's actually called, please leave me a comment below. I really would like to know. 8 times viscosity times L. L is the length of the vessel, divided by pi times a radius to the power 4. This is the radius of the vessel. Okay, so that's another way of maybe going to resistance or calculating resistance.